I'm putting these videos in one video because the loony left asks some stupid questions. For instance, what are your qualifications to call anyone mentally ill? Alright, a man who thinks he's a woman, and a woman who thinks they are a man are considered mentally ill by every real doctor of biology and doctor of psychology, and they post this stuff online. Simply Google, Doctor of Biology. What is a man? What is a woman? What is the difference between a male and female? Then you can Google Doctor of Psychology. What is gender dysphoria? You should also Google histrionic personality disorder because TikTok exists. So, even I can Google and find the information. It's getting more and more difficult as censorship increases in their attempts to normalize mental illness. Question: since when did quoting a biology book become homophobic and bigoted? First, let's start with the definition of a human. That shouldn't offend anyone. A human is a bipedal hominin characterized by having a higher and vertical forehead compared with earlier hominins. The brain volume is about 1,400 cubic centimeters. The teeth and jaw are smaller and the chin is prominent. Humans are the hominins capable of creating and using complex tools, solving problems by sense and reasoning, using symbols and language, and creating complex social structures. Over time, humans have demonstrated behavioral modernity and advancement. Male. Evil, wicked, bad. Origin, L. Malice. C. Malice. Same as male, a bag. 1. Of or pertaining to the sex that begets or procreates young, or, in a wider sense, to the sex that produces spermatozoa, by which the ova are fertilized, not female, as male organs. 2. Science, botany, capable of producing fertilization, but not of bearing fruit, set of stamens and antheridia, and of the plants, or parts of plants, which bear them. 3. Suitable to the male sex, characteristic or suggestive of a male, as male courage. 4. Consisting of males, as a male choir. 5. Science, mechanics, adapted for entering another corresponding piece, the female piece, which is hollow in which it fits, as a male gauge, for gauging the size or shape of a hole, a male screw, etc. Science, botany, male berry, a screw having threads upon its exterior which enter the grooves upon the inside of a corresponding nut or female screw. Male thread, the thread of a male screw. 1. An animal of the male sex. 2. Science, botany, a plant bearing only staminate flowers. So, male plus human equals man. And trust me, I'm only using the word man in the biological sense. Some of you barely register as human. Female. 1. An individual of the sex which conceives and brings forth young, or, in a wider sense, which was born with ovary and produces ova. Which would mean men or males can't get pregnant. 2. Science, botany, a plant which produces only that kind of reproductive organs which are capable of developing into fruit after impregnation or fertilization, a pistillate plant. Origin, OE. Femel, female, F, femel, FRL, femella, dim. Of femina woman. C. Feminine. 1. Belonging to the sex which conceives and gives birth to young, or, in a wider sense, which produces ova, not male. 2. Belonging to an individual of the female sex, characteristic of woman, feminine, as female tenderness. 3. Is science, botany, having pistils and no stamens, pistillate, or, in cryptogamous plants, capable of receiving fertilization. So, female plus human equals woman. Then of course we have the genetic level, and if you've ever watched any of the CSI shows, you know what I'm talking about. I thought that being born with ovaries was a strong enough definition of a female for the loony left. Trying to normalize mental illness. What is the difference between male and female DNA? The main difference between male and female DNA is that male DNA contains one X chromosome and one Y chromosome, whereas female DNA contains two X chromosomes. Furthermore, a particular variable region on the X chromosome of male DNA may contain either C or G, while that particular region of the X chromosome may contain either C, G, or a mixture of C and G in female DNA, proving that there are two types of X chromosomes. Moreover, all the X chromosomes of male DNA contain the same number of a particular STR, while all the X chromosomes of female DNA contains two types of that particular STRs. Male and female DNA are the two types of DNA that occur in the two genders of humans. Basically, they differ by the number of X chromosomes present and the characteristics of X chromosomes. Key areas covered. 1. What is male DNA? Definition, characteristics, importance. 2. What is female DNA? Definition, characteristics, importance. 3. What are the similarities between male and female DNA? Outline of common features. 4. What is the difference between male and female DNA? Comparison of key differences. Key terms. Female DNA, male DNA, STRs, X chromosome, Y chromosome. Difference between male and female DNA, comparison summary. What is male DNA? Male DNA is the type of DNA that occurs inside the cells of males. The main feature of male DNA is that it contains one X chromosome with the maternal origin and one Y chromosome with the fraternal origin. Therefore, male DNA contains a single type of X chromosomes. Difference between male and female DNA. On the other hand, this makes the Y chromosome the sex-determining chromosome in humans. In humans, the Y chromosome contains around 59 million base pairs and around 200 working genes. However, the expression of some of the genes in the Y chromosome occurs heterozygously. What is female DNA? Female DNA is the other type of DNA set that occurs in humans. They are present inside the female cells, and they contain two X chromosomes with different parental origins. Generally, X chromosome is around 153 million base pairs long. Moreover, it contains around 1,000 working genes. Out of this, 200 to 300 genes are uniquely expressed only in females. Other genes are similar to both males and females. Male versus female DNA. Furthermore, due to the presence of two X chromosomes with different paternal origins, the characteristics of the X chromosome can be used in the discrimination between male and female DNA. Some of these characteristics include the type of nitrogenous base present in a particular variable region on the X chromosome and number of repeats of a particular STR present in the X chromosome. Here, female DNA contains two different X chromosomes, and therefore, two variables of a particular characteristic can be identified in female DNA. However, as male DNA contains a single X chromosome, only one variable should occur out of the two in male DNA. Similarities between male and female DNA. Male and female DNA are the two sets of DNA found in humans. The characterization of male and female DNA is important for gender discrimination in forensic studies. Difference between male and female DNA. Definition: male DNA refers to the set of DNA in males, while female DNA refers to the set of DNA in females. Sex chromosomes. While male DNA contains one X chromosome and one Y chromosome, female DNA contains two X chromosomes with different origins. Thus, this is the main difference between male and female DNA. Type of sex. Furthermore, male DNA has heterogametic sex, while female DNA has homogametic sex. Karyotype. Besides, the karyotype of male DNA is 46XY, while the karyotype of female DNA is 46XX. Number of X chromosomes. Another major difference between male and female DNA is that male DNA contains only one X chromosome, while female DNA contains two X chromosomes with different origins. Number of genes. Also, the Y chromosome of males contains around 200 working genes, while the X chromosome of females contains around 1,000 working genes. Polymorphic sites. A particular variable region on the X chromosome of male DNA may contain either C or G, while that particular region of the X chromosome may contain either C, G, or a mixture of C and G in female DNA, proving that there are two types of X chromosomes. STRs. Moreover, all the X chromosomes of male DNA contain the same number of a particular STR, while all the X chromosomes of female DNA contains two types of that particular STR. Hence, this is also an important difference between male and female DNA. Sex abnormalities. Klinefelter syndrome, XXY, and XYY syndrome are the sex abnormalities associated with male DNA. Klinefelter syndrome, XXY aneuploidy, is the most common human sex chromosome disorder. Approximately 1 in 500 to 600 males is born with an extra X chromosome. The prevalence rate is 5 to 20 times higher in males who are mentally challenged than in the general male population. While Turner syndrome, X0, and XXX syndrome are the sex abnormalities associated with female karyotypes. Turner syndrome is the most common sex chromosome abnormality in females and occurs in approximately 1 in 2000 to 1 in 2500 live female births, based on epidemiological and newborn genetic screening data from Europe, Japan, and the United States. XXX syndrome, also called trisomy X or 47XXX, is a genetic disorder that affects about 1 in 1,000 females. Females normally have 2 X chromosomes in all cells, 1 X chromosome from each parent. In XXX syndrome, a female has 3 X chromosomes. They're what are known as an anomaly, a marked deviation from the normal standard, especially as a result of congenital defects. Origin, GR Animalia. Conclusion. Male DNA is the set of chromosomes that occurs inside cells of a male. Moreover, it contains 1 X chromosome from the mother and 1 Y chromosome from the father. As it contains a single X chromosome, a particular variable region contains a single type of base. However, in female DNA, there can be 2 different types of bases in the 2 X chromosomes. Also, the X chromosomes of male DNA contains a single type of a particular STR. But, in female DNA, there can be 2 types of a particular STR since female DNA contains 2 X chromosomes. Basically, these are due to the presence of 2 X chromosomes in female DNA. Therefore, the main difference between male and female DNA is the type of sex chromosomes present in each type of DNA. I was called a science denier by a loony leftist who thinks men should compete against women, college student who happened to be studying biology who for some reason doesn't know biology. Another video made courtesy of biologists. I only seek out the best. Men versus women are key physical differences explained. Introduction. Sexual dimorphism is the scientific term for physical differences between males and females of a species. Many extreme examples exist. Peacocks far outclass peahens, for instance, while female anglerfish both outsize and outwit their tiny, rudimentary, parasitic male counterparts. Unlike those animals, men and women are more physically similar than we are different. Nonetheless, there are a few key distinctions in our physiques. Some of them are designed to suit each sex for the role it plays in reproduction, while others exist to help us tell each other apart and to aid in our mutual attraction. Women have breasts, whereas men have flat chests, but still with nipples on them. Why? Women are the only primates who are busty all the time, even when they aren't nursing. Alternative theories exist, but most scientists think breasts are an evolutionary trick for snagging men, though they're actually filled with fat, not milk. They signal a woman's bountiful ability to feed her children. Breasts also help men figure out who to pursue to achieve reproductive success. Prepubescent girls don't have breasts, and the breasts of postmenopausal women are often shrunken and saggy. A full, buoyant bosom can therefore demonstrate fertility. Men aren't trying to trick women into thinking they can breastfeed, so they don't have breasts. They do, however, have nipples. This is because the genes that code for nipple development switch on in utero, and at a very early embryonic stage even before the genes gear up that turn us into males or females. Big apple versus small. Men and women both have cartilage surrounding their voice boxes, but because men have bigger boxes, which give them deeper voices, their chunks of cartilage protrude more. This gives them neck lumps called Adam's apples. But why do men have deeper voices than women? The answer is that the pitch of a man's voice correlates with the amount of the male sex hormone testosterone he has, and his testosterone level is itself indicative of his genetic quality and sexual fitness. Because women have evolved to seek out men who have all the indicators of fitness and health, studies have shown time and time again that women tend to be more attracted to men with lower-pitched voices. They're looking for a mate with whom to produce healthy offspring. Square versus heart-shaped faces. The more testosterone a man has, the stronger his brow, cheekbones, and jawline. Meanwhile, the more estrogen a woman has, the wider her face, fuller her lips, and the higher her eyebrows. In short, sex hormones control the divergence of male and female facial features. Along with chiseled jaws, higher testosterone has been shown to correlate with muscle strength and aggression in men, as well as with genetic vigor. Perhaps for this reason, studies have shown that women judge men with more angular features as likely to be dominant over men with rounder, more effeminate faces. They also tend to rate men with masculine features as more attractive, especially when they themselves are ovulating and, thus, at least subconsciously, on the lookout for a male sex partner who'll produce fit offspring. When they're looking for a long-term partner, on the other hand, studies show that women tend to prefer men with more effeminate features, who have less testosterone and are likely to be more loyal partners and caring fathers. Hairy versus not. From puberty on, men grow much more hair on their bodies and especially their faces than women. This is because sex hormones, called androgens, stimulate hair growth, and men have more of those hormones. But what determines the pattern of male hair growth? And in particular, why do men have beards? Most evolutionary psychologists believe beards became prevalent because, for most of our evolutionary past, women found men with facial hair more attractive than men without it, and thus were more likely to mate with bearded men. This attraction could arise because beards not only signal high testosterone levels, they also signify sexual maturity, in much the same way as breasts on women, as well as possibly signifying dominance by increasing the perceived size of a man's jaws. On the flip side, the same testosterone that sprouts hair all over men's bodies also leads them to go bald later in life. Fair versus swarthy. Handsome men are often depicted as dark, while beautiful women are stereotyped as blonde and fair-skinned. These stereotypes are not limited to Anglo-European cultures, as one might imagine. In the foreword of a 2005 book on the subject, Fair Women, Dark Men by Peter Frost, University of Washington sociologist Pierre van den Berg wrote, although virtually all cultures express a marked preference for fair female skin, even those with little or no exposure to European imperialism, and even those whose members are heavily pigmented, many are indifferent to male pigmentation or even prefer men to be darker. These widespread preferences may reflect the fact that, from puberty on, and in all populations, women tend to have lighter skin, hair and eyes than men do, and so opinions about the ideal coloring for each gender may reflect pigmentations that are inherently more masculine and more feminine. The lightness of a woman's skin correlates with the ratio of the lengths of her index and ring fingers, and her digit ratio in turn correlates with how much estrogen she was exposed to in the womb. For this reason, scientists believe it is exposure to estrogen before birth that somehow programs the lightening of female skin during puberty. Similarly, studies have also found that digit ratios are higher among blonde people than dark-haired ones, suggesting that higher estrogen exposure also lightens hair. Muscular versus curvy. Men are, in general, more muscular than women. Women are just over half as strong as men in their upper bodies, and about 2/3 as strong in their lower bodies. Right there is how a man is breaking swimming records in a women's sport. Even with a year of hormone treatments, a man will only lose 5% of his muscle, and 0 bone density. If you're a man who has to compete against women to be a champion, you're not a champion, you're a cheater. Simple as that. While the male metabolism burns calories faster, the female metabolism tends to convert more food to fat. Women store the extra fat in their breasts, hips, buttocks, and as subcutaneous fat in the bottom layer of their skin, giving a woman's skin its softer, plumper feel. Male and female bodies are well designed for each gender's role in a primitive society. Women are built for carrying and birthing children, and must have wider hips and keep extra fat in store for the ordeal of pregnancy. Men, free from the requirements of childbirth, benefit from being as strong and lithe as possible, both in their search for food, and when in competition with other men. Sex reassignment doesn't work. Here is the evidence. Key takeaways. McHugh points to the reality that because sex change is physically impossible, it frequently does not provide the long-term wholeness and happiness that people seek. Unfortunately, many professionals now view healthcare, including mental health care, primarily as a means of fulfilling patients' desires, whatever those are. Our brains and senses are designed to bring us into contact with reality, connecting us with the outside world and with the reality of ourselves. Sex reassignment doesn't work. It's impossible to reassign someone's sex physically, and attempting to do so doesn't produce good outcomes psychosocially. As he demonstrates in his book, When Harry Became Sally, Responding to the Transgender Moment, the medical evidence suggests that sex reassignment does not adequately address the psychosocial difficulties faced by people who identify as transgender. Even when the procedures are successful technically and cosmetically, and even in cultures that are relatively trans-friendly, transitioners still face poor outcomes. Dr. Paul McHugh, the University Distinguished Service Professor of Psychiatry at the Johns Hopkins University School of Medicine, explains. Transgendered men do not become women, nor do transgendered women become men. All, including Bruce Jenner, become feminized men or masculinized women, counterfeits or impersonators of the sex with which they identify. In that lies their problematic future. When the tumult and shouting dies, it proves not easy nor wise to live in a counterfeit sexual garb. The most thorough follow-up of sex reassigned people, extending over 30 years and conducted in Sweden, where the culture is strongly supportive of the transgendered, documents their lifelong mental unrest. 10 to 15 years after surgical reassignment, the suicide rate of those who had undergone sex reassignment surgery rose to 20 times that of comparable peers. McHugh points to the reality that because sex change is physically impossible, it frequently does not provide the long-term wholeness and happiness that people seek. Indeed, the best scientific research supports McHugh's caution and concern. Here's a summarized review of more than 100 follow-up studies of post-operative transsexuals by Birmingham University's Aggressive Research Intelligence Facility. The Aggressive Research Intelligence Facility, which conducts reviews of healthcare treatments for the National Health Service, concludes that none of the studies provides conclusive evidence that gender reassignment is beneficial for patients. It found that most research was poorly designed, which skewed the results in favor of physically changing sex. There was no evaluation of whether other treatments, such as long-term counseling, might help transsexuals, or whether their gender confusion might lessen over time. There is huge uncertainty over whether changing someone's sex is a good or a bad thing, said Chris Hyde, the director of the facility. Even if doctors are careful to perform these procedures only on appropriate patients, Hyde continued, there's still a large number of people who have the surgery but remain traumatized, often to the point of committing suicide. Of particular concern are the people these studies lost track of. As has been noted, the results of many gender reassignment studies are unsound because researchers lost track of more than half of the participants. Indeed, Dr. Hyde said the high dropout rate could reflect high levels of dissatisfaction or even suicide among post-operative transsexuals. Hyde concluded, the bottom line is that although it's clear that some people do well with gender reassignment surgery, the available research does little to reassure about how many patients do badly and, if so, how badly. The facility conducted its review back in 2004, so perhaps things have changed in the past decade? Not so. In 2014, a new review of the scientific literature was done by Hayes Incorporated, a research and consulting firm that evaluates the safety and health outcomes of medical technologies. Hayes found that the evidence on long-term results of sex reassignment was too sparse to support meaningful conclusions and gave these studies its lowest rating for quality. Statistically significant improvements have not been consistently demonstrated by multiple studies for most outcomes. Evidence regarding quality of life and function in male-to-female adults was very sparse. Evidence for less comprehensive measures of well-being in adult recipients of cross-sex hormone therapy was directly applicable to gender dysphoric patients but was sparse and/or conflicting. The study designs do not permit conclusions of causality, and studies generally had weaknesses associated with study execution as well. There are potentially long-term safety risks associated with hormone therapy, but none have been proven or conclusively ruled out. The Obama administration came to similar conclusions. In 2016, the Centers for Medicare and Medicaid Services revisited the question of whether sex reassignment surgery would have to be covered by Medicare plans. Despite receiving a request that its coverage be mandated, it refused, on the ground that we lack evidence that it benefits patients. Here's how the June 2016 proposed decision memo for gender dysphoria and gender reassignment surgery put it. Based on a thorough review of the clinical evidence available at this time, there is not enough evidence to determine whether gender reassignment surgery improves health outcomes for Medicare beneficiaries with gender dysphoria. There were conflicting, inconsistent study results of the best designed studies. Some reported benefits while others reported harms. The quality and strength of evidence were low due to the mostly observational study designs with no comparison groups, potential confounding, and small sample sizes. Many studies that reported positive outcomes were exploratory type studies, case series and case control, with no confirmatory follow-up. The final August 2016 memo was even more blunt. It pointed out, overall, the quality and strength of evidence were low due to mostly observational study designs with no comparison groups, subjective endpoints, potential confounding, a situation where the association between the intervention and outcome is influenced by another factors such as a co-intervention, small sample sizes, lack of validated assessment tools, and considerable loss to follow-up. That loss to follow-up, remember, could be pointing to people who committed suicide. And when it comes to the best studies, there is no evidence of clinically significant changes after sex reassignment. The majority of studies were non-longitudinal, exploratory type studies, i.e., in a preliminary state of investigation or hypothesis generating, or did not include concurrent controls or testing prior to and after surgery. Several reported positive results, but the potential issues noted above reduced strength and confidence. After careful assessment, we identified 6 studies that could provide useful information. Of these, the 4 best designed and conducted studies that assessed quality of life before and after surgery using validated, albeit non-specific, psychometric studies did not demonstrate clinically significant changes or differences in psychometric test results after gender reassignment surgery. In a discussion of the largest and most robust study, the study from Sweden that McHugh mentioned in the quote above, the Obama Centers for Medicare and Medicaid Services pointed out the 19 times greater likelihood for death by suicide, and a host of other poor outcomes. The study identified increased mortality and psychiatric hospitalization compared to the matched controls. The mortality was primarily due to completed suicides, 19.1-fold greater than in control Swedes, but death due to neoplasm and cardiovascular disease was increased 2 to 2.5 times as well. We note, mortality from this patient population did not become apparent until after 10 years. The risk for psychiatric hospitalization was 2.8 times greater than in controls even after adjustment for prior psychiatric disease, 18%. The risk for attempted suicide was greater in male to female patients regardless of the gender of the control. Further, we cannot exclude therapeutic interventions as a cause of the observed excess morbidity and mortality. The study, however, was not constructed to assess the impact of gender reassignment surgery per se. These results are tragic. And they directly contradict the most popular media narratives, as well as many of the snapshot studies that do not track people over time. As the Obama Centers for Medicare and Medicaid pointed out, mortality from this patient population did not become apparent until after 10 years. So when the media tout studies that only track outcomes for a few years, and claim that reassignment is a stunning success, there are good grounds for skepticism. As he explained in his book, these outcomes should be enough to stop the headlong rush into sex reassignment procedures. They should prompt us to develop better therapies for helping people who struggle with their gender identity. And none of this even begins to address the radical, entirely experimental therapies that are being directed at the bodies of children to transition them. Sex change is physically impossible. We've seen some of the evidence that sex reassignment doesn't produce good outcomes psychosocially. And as McHugh suggested above, part of the reason why is because sex change is impossible and it proves not easy nor wise to live in a counterfeit sexual garb. But what is the basis for the conclusion that sex change is impossible? Contrary to the claims of activists, sex isn't assigned at birth, and that's why it can't be reassigned. As was explained in When Harry Became Sally, sex is a bodily reality that can be recognized well before birth with ultrasound imaging. The sex of an organism is defined and identified by the way in which he or she is organized for sexual reproduction. This is just one manifestation of the fact that natural organization is the defining feature of an organism, as neuroscientist Maureen Kondik and her philosopher brother Samuel Kondik explain. In organisms, the various parts are organized to cooperatively interact for the welfare of the entity as a whole. Organisms can exist at various levels, from microscopic single cells to sperm whales weighing many tons, yet they are all characterized by the integrated function of parts for the sake of the whole. Male and female organisms have different parts that are functionally integrated for the sake of their whole, and for the sake of a larger whole, their sexual union and reproduction. So an organism's sex, as male or female, is identified by its organization for sexually reproductive acts. Sex as a status, male or female, is a recognition of the organization of a body that can engage in sex as an act. That organization isn't just the best way to figure out which sex you are. It's the only way to make sense of the concepts of male and female at all. What else could maleness or femaleness even refer to, if not your basic physical capacity for one of two functions in sexual reproduction? The conceptual distinction between male and female based on reproductive organization provides the only coherent way to classify the two sexes. Apart from that, all we have are stereotypes. This shouldn't be controversial. Sex is understood this way across sexually reproducing species. No one finds it particularly difficult, let alone controversial, to identify male and female members of the bovine species or the canine species. Farmers and breeders rely on this easy distinction for their livelihoods. It's only recently, and only with respect to the human species, that the very concept of sex has become controversial. And yet, in an expert declaration to a federal district court in North Carolina concerning HB 2, a state law governing access to sex-specific restrooms, Dr. Deanna Adkins stated, "From a medical perspective, the appropriate determinant of sex is gender identity." Adkins is a professor at Duke University School of Medicine and the director of the Duke Center for Child and Adolescent Gender Care, which opened in 2015. Adkins argues that gender identity is not only the preferred basis for determining sex, but the only medically supported determinant of sex. Every other method is bad science, she claims. It is counter to medical science to use chromosomes, hormones, internal reproductive organs, external genitalia, or secondary sex characteristics to override gender identity for purposes of classifying someone as male or female. In her sworn declaration to the federal court, Adkins called the standard account of sex, an organism's sexual organization, an extremely outdated view of biological sex. Dr. Lawrence Mayer responded in his rebuttal declaration, "This statement is stunning. I have searched dozens of references in biology, medicine and genetics, even Wiki, and can find no alternative scientific definition. In fact, the only references to a more fluid definition of biological sex are in the social policy literature." Just so. Mayer is a scholar in residence in the Department of Psychiatry at the Johns Hopkins University School of Medicine and a professor of statistics and biostatistics at Arizona State University. Modern science shows that our sexual organization begins with our DNA and development in the womb, and that sex differences manifest themselves in many bodily systems and organs, all the way down to the molecular level. In other words, our physical organization for one of two functions in reproduction shapes us organically, from the beginning of life, at every level of our being. Cosmetic surgery and cross-sex hormones can't change us into the opposite sex. They can affect appearances. They can stunt or damage some outward expressions of our reproductive organization. But they can't transform it. They can't turn us from one sex into the other. Scientifically speaking, transgender men are not biological men and transgender women are not biological women. The claims to the contrary are not supported by a scintilla of scientific evidence, explains Mayer. Or, as Princeton philosopher Robert P. George put it, changing sexes is a metaphysical impossibility because it is a biological impossibility. The purpose of medicine, emotions, and the mind. Behind the debates over therapies for people with gender dysphoria are two related questions. How do we define mental health and human flourishing? And what is the purpose of medicine, particularly psychiatry? Those general questions encompass more specific ones. If a man has an internal sense that he is a woman, is that just a variety of normal human functioning, or is it a psychopathology? Should we be concerned about the disconnection between feeling and reality, or only about the emotional distress or functional difficulties it may cause? What is the best way to help people with gender dysphoria manage their symptoms? By accepting their insistence that they are the opposite sex and supporting a surgical transition, or by encouraging them to recognize that their feelings are out of line with reality and learn how to identify with their bodies? All of these questions require philosophical analysis and worldview judgments about what normal human functioning looks like and what the purpose of medicine is. Settling the debates over the proper response to gender dysphoria requires more than scientific and medical evidence. Medical science alone cannot tell us what the purpose of medicine is. Science cannot answer questions about meaning or purpose in a moral sense. It can tell us about the function of this or that bodily system, but it can't tell us what to do with that knowledge. It cannot tell us how human beings ought to act. Those are philosophical questions, explained in When Harry Became Sally. While medical science does not answer philosophical questions, every medical practitioner has a philosophical worldview, explicit or not. Some doctors may regard feelings and beliefs that are disconnected from reality as a part of normal human functioning and not a source of concern unless they cause distress. Other doctors will regard those feelings and beliefs as dysfunctional in themselves, even if the patient does not find them distressing, because they indicate a defect in mental processes. But the assumptions made by this or that psychiatrist for purposes of diagnosis and treatment cannot settle the philosophical questions. Is it good or bad or neutral to harbor feelings and beliefs that are at odds with reality? Should we accept them as the last word, or try to understand their causes and correct them, or at least mitigate their effects? While the current findings of medical science, as shown above, reveal poor psychosocial outcomes for people who have had sex reassignment therapies, that conclusion should not be where we stop. We must also look deeper for philosophical wisdom, starting with some basic truths about human well-being and healthy functioning. We should begin by recognizing that sex reassignment is physically impossible. Our minds and senses function properly when they reveal reality to us and lead us to knowledge of truth. And we flourish as human beings when we embrace the truth and live in accordance with it. A person might find some emotional relief in embracing a falsehood, but doing so would not make him or her objectively better off. Living by a falsehood keeps us from flourishing fully, whether or not it also causes distress. This philosophical view of human well-being is the foundation of a sound medical practice. Dr. Michelle Cretella, the president of the American College of Pediatricians, a group of doctors who formed their own professional guild in response to the politicization of the American Academy of Pediatrics, emphasizes that mental health care should be guided by norms grounded in reality, including the reality of the bodily self. The norm for human development is for one's thoughts to align with physical reality, and for one's gender identity to align with one's biologic sex, she says. For human beings to flourish, they need to feel comfortable in their own bodies, readily identify with their sex, and believe that they are who they actually are. For children especially, normal development and functioning require accepting their physical being and understanding their embodied selves as male or female. Unfortunately, many professionals now view healthcare, including mental health care, primarily as a means of fulfilling patients' desires, whatever those are. In the words of Leon Kass, a professor emeritus at the University of Chicago, today a doctor is often seen as nothing more than a highly competent hired syringe. The implicit, and sometimes explicit, model of the doctor-patient relationship is one of contract. The physician, a highly competent hired syringe, as it were, sells his services on demand, restrained only by the law, though he is free to refuse his services if the patient is unwilling or unable to meet his fee. Here's the deal: for the patient, autonomy and service; for the doctor, money, graced by the pleasure of giving the patient what he wants. If a patient wants to fix her nose or change his gender, determine the sex of unborn children, or take euphoriant drugs just for kicks, the physician can and will go to work, provided that the price is right and that the contract is explicit about what happens if the customer isn't satisfied. This modern vision of medicine and medical professionals gets it wrong, says Kass. Professionals ought to profess their devotion to the purposes and ideals they serve. Teachers should be devoted to learning, lawyers to justice, clergy to things divine, and physicians to healing the sick, looking up to health and wholeness. Healing is the central core of medicine. Cass writes, to heal, to make whole, is the doctor's primary business. To provide the best possible care, serving the patient's medical interests requires an understanding of human wholeness and well-being. Mental health care must be guided by a sound concept of human flourishing. The minimal standard of care should begin with a standard of normality. Kretella explains how this standard applies to mental health. One of the chief functions of the brain is to perceive physical reality. Thoughts that are in accordance with physical reality are normal. Thoughts that deviate from physical reality are abnormal, as well as potentially harmful to the individual or to others. This is true whether or not the individual who possesses the abnormal thoughts feels distress. Our brains and senses are designed to bring us into contact with reality, connecting us with the outside world and with the reality of ourselves. Thoughts that disguise or distort reality are misguided and can cause harm. In When Harry Became Sally, it is argued that we need to do a better job of helping people who face these struggles.
Let me explain why all of these made-up sexual terms suddenly appeared. It has nothing to do with actual sexuality. It has to do with, look at me, I have no talent, no skill, nothing that makes me stand out, but I want attention so badly. I know, now I'm a made-up pronoun sexual. I'm a minority now. No, you have a mental disorder that requires treatment, not stupid videos on TikTok telling the world some word you made up. My pronouns are. No one cares. This is also why they're losing their minds about Florida's new law, because they won't be able to tell your kids about their private life. It bothers them because kids are generally the only ones who would care. Does anyone know why the loony left is trying to normalize mental illness? Would a sane person vote Democrat in the 21st century? What most of these people have, and not the trans people actually have gender dysphoria. I'm talking about the pronoun making attention seekers, who just add some made-up prefix to the word sexual. They're attention seekers, and they have a real mental illness. I personally believe sites such as TikTok have only intensified this in some people. Histrionic personality disorder and BPD. Histrionic personality disorder, HPD, is a personality disorder that tends to co-occur with other personality disorders, particularly borderline personality disorder, BPD, narcissistic, and dependent personality disorders. There is a great deal of overlap between BPD and HPD features, so much so that some experts believe that HPD may not actually be distinguishable from BPD. Understanding histrionic personality disorder. HPD is one of 10 personality disorders recognized in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-5. It should also be noted that gender dysphoria is also recognized in DSM-5. HPD is one of the cluster B disorders, which are characterized as dramatic, overly emotional, and/or erratic. The DSM-5 defines histrionic personality disorder as a pattern of extreme emotionality and attention-seeking behavior that begins by early adulthood and is obvious in different situations. In addition, you must have 5 or more of the following signs or symptoms to be diagnosed with HPD. Discomfort in situations in which you're not the center of attention. Interaction with others that's often characterized by inappropriate sexually seductive or provocative behavior. Rapidly shifting and shallow expression of emotion. Consistently uses physical appearance to draw attention to self. Style of speech that is excessively impressionistic and lacking in detail. Shows self-dramatization, theatricality, and exaggerated expression of emotion. Is easily influenced by others or by circumstances. Considers relationships to be more intimate than they actually are. People with HPD might be described as being overly dramatic, emotional, or attention-seeking. This pattern of behavior rises to the level of a clinical disorder when it significantly interferes with relationships, work, or other important domains in life. Co-occurrence of HPD and BPD. There are only a few studies that have examined the co-occurrence of HPD and BPD. One often quoted study found that HPD frequently occurs with BPD. In another study that used a community sample, about 10% of people with BPD also met criteria for HPD. HPD versus BPD. There is a marked overlap between the symptoms of HPD and BPD. For example, both share the features of rapidly shifting and reactive emotions, both are associated with impulsive behavior, and both are characterized by a very strong expression of emotion. While some clinicians argue that the qualities of these symptoms are different in HPD versus BPD, for example, that the rapidly shifting emotions in HPD are not experienced with the same depth and intensity as those in BPD, other experts have argued that HPD and BPD are not necessarily distinct disorders. However, despite predictions that the HPD diagnosis would be dropped in DSM-5, it was not, and so it remains its own specific and unique diagnosis. Treatment. While there is some advice for clinicians treating HPD, it's generally based on expert opinion or experiences rather than on research data. Much more research is needed on this topic, but in general, psychotherapy is often used and may be helpful. If you have symptoms of other issues such as depression or anxiety, medication may help to alleviate those symptoms as well.